Good evening, Endo Summit Live, and welcome to our fertility episode this evening, where we're talking all about the embryo and egg quality. Welcome back, Emma. You want to go ahead and introduce yourself?
Of course. Hi, everyone. Hi. So my name is Emma, and I'm a senior embryologist and a fertility and immunology specialist. Now, I work many years in the embryology lab, almost 20 years. But now I'm dedicated more to medical education of patients, especially for fertility and endometriosis. So tonight, I would love to explain to you something more about egg quality and embryo quality, especially from my side as an embryologist. Okay, so I'm gonna share my screen, okay, because I have a presentation ready. 1 second. Okay, it is. 1 second. Let me see. Let me go back 1 second. Okay, but this is my presentation.
Just for those of you out there watching, Zoom updated today,
Yeah.
so we're finding our way through it. So just be very patient.
Yes, be patient, please. I'm
Because all
checking.
the buttons are all of a sudden different. So usually
Yeah.
I go, we've been doing this since 2020, but really today we've been doing it about 3 minutes. So
Yes, yes. Give me a second because that's right. Everything changed, and it's so weird. Let me see
it
screen.
is. It's like 6 years it was one way. And then today it's all different.
Yeah.
No warning, no email, no nothing.
Okay, almost there. I'm almost there. Okay.
If you are logged on to our Zoom, feel free to put your fertility embryology based questions in
Yes,
the
please.
Q&A, please.
Yes,
We
yes.
are looking forward to answering those questions.
Yeah, I'm almost there. Here we go, probably. Here we go.
Wasn't it worth it? Look how good she looks.
So now you see the background?
Yes, now we see.
Okay, perfect, perfect. So I'm gonna start, okay? Continue to share. So you see, right?
We see.
Perfect. Okay. So again, my name is Emanuela Lazzaroni, but everybody actually call me Emma because it's easier, shorter. And I'm a senior embryologist and I work at ESSI as fertility and immunology specialist. So tonight, as I anticipated, I'm gonna talk about egg quality and embryo quality. And especially what does it mean as quality biologically? So in IVF lab, embryologists assess microscopic structure and developmental patterns that reflect the underlying biology of egg and embryo. So today, we will follow this journey from the oocyte up to the blastocyst. Okay, so let's start. Okay, so where actually the embryo quality begin? So this is actually a very important question. And is a fundamental concept in reproductive biology that actually the embryo quality start with the egg. So when we talk about embryo quality, it's not just the embryo, but before that embryo, the majority for the first 3 days was an egg. So before fertilization occurs, the oocyte already contains everything necessary to support an early embryo development. And these actually include maternal mRNA, proteins, organelles, and so everything rely on the egg. So the eggs are important, are fundamental. So because, but why in the early stage, everything relied to the egg? Because initially, the DNA, the genome of the embryo is inactive. So initially, but we need to consider that what is actually working is through the genome of the egg. Okay, let's continue. Okay, now, what's the timeline? So we know, everybody probably know that we start with an egg oocyte, then we fertilize the egg, then the egg start, after the egg got fertilization, that at that point is a zygote, the zygote start cleaving. After cleavage, the embryo become a morula, and then after morula, the embryo become a blastocyst. So this is the timeline. And embryologists observe the morphology of from the egg to the embryo, to the morula, to the blastocyst, plus every developmental progression that occurs. Okay, so as I said, maternal to zygotic transition, okay? So during the first few days of development, the embryo is still using molecular instruction got from the egg, as we said, so maternal. Eventually, the embryo must activate later on the genome. So this process, so initially from the maternal egg and then to the embryo, is called maternal to zygotic transition. And this transition, it happened after day 3. So basically when the embryo is 4 to 8 cells, then it starts to activate its own genome. Okay, now let's discuss a little bit about what is inside an oocyte. Well, everybody knows that an oocyte is a cell with a cytoplasm, with a nucleus, with a membrane, and with a zona outside, okay? So what is crucial are some structures that are inside the cytoplasm. So egg quality is strongly influenced by the organization of the cytoplasm in the egg. And these structures that are inside are really the key drivers of the whole process. First one, mitochondria. Now it's been like a few years that we keep, hearing that there are studies on mitochondria. And so definitely mitochondria are fundamental, are probably one of the number one key driver. Then the spindle integrity, and then the cytoskeleton organization. So let me just briefly explain what these key drivers are. So mitochondria are small organelles that are inside the cytoplasm that provide the energy to the egg. So they provide ATP. Obviously, without mitochondria, nothing impossible in the cell. No other, source of, energy are in the egg except the mitochondria. So they are fundamental. That's why in the latest research, we are really talking a lot about mitochondria. Then we have the spindle. So the spindle is a structure made of microtubules that organize the chromosome during cell division. And it's super fundamental, the spindle, because it helps the properly separation of the chromosomes when is, time of the meiosis. So basically, when the egg finish the meiosis 2, the M2, the spindle work in a way that the chromosome are really well separated. And if for some reason this spindle function is not working, chromosome may segregate incorrectly, and we can have aneuploid embryos. So these are, one of the reasons of embryo aneuploidy. So that probably the spindle is not functioning properly. And now, what is the cytoskeleton? Already, the word skeletal is a structure inside the cytoplasm that actually distribute all these organelles like mitochondria or spindle positioning or other organelles inside the whole cytoplasm. Okay, now, as women age, several molecular processes affect egg quality. So recent research showed that aging oocytes experience disruption in protein homeostasis or proteostasis. This means proteins may accumulate damage or misfold. So also there are other situations with the aging. Change like changing ribosomal function and other like epigenetic regulation are not working properly anymore. So today, I want to explain to you how and let you understand how the oocyte is fundamental for first having a viable embryo and later on a successful pregnancy. Because all of these alterations inside the oocyte can impair the ability of the egg to support normal embryonic development. Okay, now you can see these beautiful eggs. So some, they don't even look egg. So basically, when embryologists evaluate oocytes, we sometimes, as you can see from this picture, observe, and I think that everybody, you don't need to be an embryologist, very abnormal characteristics. For example, if you can see, there is I see top right, there is this egg. Oh, do you see my arrow?
Yeah.
Okay, so this egg, you see how long it is? So it doesn't even look like an egg, round. So this is very, very, and actually you cannot imagine how many I found like this. Or for example, you can see these are actually vacuoles. Vacuoles are like, they look like little bubble inside the cytoplasm. Or for example, look at the bottom here. This is the polar body. This polar body is quite big. So this is a characteristic that, we can definitely see right away. And let's not talk about this one. Everything is wrong in this one. The color, the granularity. So, there are several features that you can, observe when you check at the quality of the oocytes. Okay, so now this is something that I want to mention, that in 2015, I actually published a paper as a first author on PLOS ONE, where in these studies, I was systematically evaluating if morphology of the oocyte could be integrated into a composite scoring system. So in this study, that was a predictive cohort study, we assess 6 multiple morphological parameters of the oocytes. So these parameters that we were observing were the oocyte morphology and overall appearance, like before when I said, oh, this one has everything wrong. So definitely that one was poor, looking at the overall appearance. Then we were looking at the cytoplasm characteristics. So the cytoplasm, you know, sometimes you see the cytoplasm that is very, very granular. And that is something that obviously you prefer to not have. We were looking at the zona pellucida. The zona pellucida is actually this part, see? And the zona, it can be like thick, thin, can have like a kind of too dark color. So we were looking at, you know, these characteristics. Also, we were looking at the PVS. PVS is the perivitelline space. That is this space that is between the zona pellucida and the membrane, that is this one, of the egg. And we were looking at this space. This space sometimes is too large, too big, sometimes too thin, so too attached, and sometimes is even granular. You can see a lot of granules inside here. And then we were looking at the polar body. As I mentioned before, that egg had a very big polar body. So we were looking if the polar body was too big, was too small, was fragment. So all of these characteristics. And last characteristic, we were looking at the size of the oocyte. And the size, you know, we were measuring the diameter from internal membrane to side. And, you know, if we're too big, too small, so we put all together and we develop a scoring system that actually combine all of these characteristics and parameters to see if they were correlated with the embryo development. So we wanted to see, initially, we check, like, for example, is the big polar body related to arrested embryo on day 3 or like very poor embryo quality? But then at the end, what we found out was that the combination, okay, of some specific characteristics were associated with lower developmental potential and higher oocyte score significantly increase the chance of pregnancy. That is kind of pretty obvious that, of course, good egg, good embryo, and then pregnancy. But what was actually very interesting was that the egg quality came out to be a multifactorial and depending on the combination of structural and molecular factors rather than a single morphological marker. So actually this study was, it was very, I would say, important, again, to give, to understand that the embryo actually really rely on the egg quality. Okay, so let's continue. Okay, now we talk about the egg. So what we do with the egg? So we try to fertilize. Okay, so when we have, let's say, 2 methods to fertilize the eggs. One is through the ICSI, that is the intracytoplasmic sperm injection, or through conventional IVF. That does mean that we put all the sperm around in a certain concentration and they do by themselves. Okay, so after fertilization, so after one of the sperm get in, the embryo start to enter a pronuclear stage. So a normal fertilization is identified by two pronuclei. Okay, so look at this. So this is our egg, and these are two pronuclei. So one from the father, one from the mother. Okay, I don't know if now is one from the father or one from the mother, but is one from each part. Okay, and this is the normal fertilization because it makes sense, of course. One from the mother, one from the father, right? And as embryologists, sometimes actually we even assess their symmetry and alignment. But okay, here we can have also an abnormal fertilization. And what is an abnormal fertilization? So instead of having two PN, we can have one PN, so one from or the mother or the father, or eventually three PN. And you would ask why I can, end up with the 3 p.m. Well, 3 p.m. and actually is quite common. And if in our audience we have many people that went through IVF, probably they heard, it's very light, I would say, that if you do several IVF cycles, it might happen to you that in the morning after the fertilization, when they do the fertilization check, the embryologist or whoever call you to give you the update will say, okay, so you have like three that fertilize normally and one fertilize abnormally. Okay, that one is probably a 3PN. And why is 3? Because it's a chromosomal error, or eventually it can be that we have more than one sperm inside the oocyte. So with ICSI, so when the embryologist put the sperm inside the egg, it's quite difficult that you put two sperm. But in nature, that, usually what happened? One sperm get in and automatically the egg shut off and doesn't allow any other sperm to go in. If something is wrong, especially when the age goes of the woman, goes up, some of these process do not work perfectly. So it's very possible that two sperm go inside, and that's why we can have 3PN. Okay, so this is an embryo. Actually, this is a very nice embryo. It's an embryo at cleavage stage. So it means that after the fertilization, so after we have our, let's say, 2PN oocyte, the day after, we go and check if the oocyte, actually the zygote, start dividing. So on day 2, usually the embryo has between 2 and 4 cells. On day 3, the embryo has between 6 to 10 cells. And during this stage, as embryologists, we evaluate the symmetry of the cells, if any fragmentation, and the nuclear integrity. Okay, so here you can see that there are some timing. So the morphokinetics is really the time of cell division. So the first cell division is, after the fertilization, 25 hours after fertilization, the embryo should be 2 cells. 37 hours should be 3 cells. 50 hours after fertilization should be 5 cells. and like approximately 110 hours after fertilization should be a blastocyst. Okay, now I said that we check at some parameters in the embryo, and the fragmentation is one of those. So what is the fragmentation? Fragmentation refers to cytoplasmic fragments that appear between blastomere. First of all, blastomere are the cells that make an embryo, and the fragments, they are cytoplasm, piece of cytoplasm without any DNA that go in between the blastomere. And if the fragmentation is low, we can give a good grade to that embryo. If the fragmentation is a little more high, is an average embryo. If the fragmentation is high, definitely it doesn't look like a very good one. So we can see here that the first one has zero fragmentation. The second one has less. You can see a little bit here than 10%. The third one has between 11 and 20% fragmentation. And actually this one is more than 25% fragmentation. You can tell that is not the best of the best embryo. Okay, so then also we check, sometimes are not very visible, but sometimes yes, we can see the nuclei inside each blastomere, okay? A blastomere is a cell, okay? So as every cell, there is one DNA. So one nuclei, sorry. So if the nucleus is one, means everything is fine. If we see more than one inside one blastomere, like 2, 3, like in this case are 3, because you can see 1, 2, and this one is little 3, it means that something is wrong, and there are most likely chromosomal abnormalities, and definitely there is a reduced implantation chance. Okay, day 4. So we talk about day 0, we have the egg. Day 1, we have the zygote. Day 2, we have a 2-4 cells embryo. Day 3, we have approximately 8 cells embryos, and now we are on day 4. Day 4, we are at the morula stage. Okay, what is a morula? The morula is an embryo that is made by approximately 16 to 32 cells. But the most important thing of the morula, that the morula, is like a ball. So it's not like that you see as the embryo before, the cell that are separated, but actually in the morula, these blastomere that, they have an increased number, like 16 to 32 cells, the blastomere are like a glue together. So they are like one whole thing, okay? And the morula actually is the step that marks the transition toward then the formation of the blastocyst. Okay, and now we talk about blastocyst. I think that everyone heard blastocyst, because in the last, I would say that 15 years, 10, 15 years, we focus a lot of our research and, process in the lab around the blastocyst. Okay, so the blastocyst, usually it occurs, the blastocyst stage, on day 5, day 6, and sometimes even day 7, even if it would be better to have a blastocyst on day 5 or day 6. So the blastocysts contain 2 kinds of cells population. One is the inner cell mass that actually is abbreviate ICM. So probably some people that went through IVF, probably, they heard the term ICM, that is the inner cell mass, and is actually the part that is gonna form then the baby. And the ICM is about roughly like 30 cells. And then we have another part that is the trophectoderm. The trophectoderm actually is what it's going to be the placenta. And is about, let's say, between 70 and 150 cells. And then we have the cavity inside the blastocyst that is always abbreviated BC. That is actually the blastocele. Okay, now, how do we grade the blastocyst? Well, you can see here, and this is actually a pretty good, let's say, diagram of, embryo scoring, how you score, how you give the quality, how you grade. So look at here. This is the ICM, okay? And this is the trophectoderm. Then here is another ICM. Here is another. Here is another. Here and here, here. But here is not very, we cannot really see so well. So this is a beautiful IVM. ICM. And even I would say this is a beautiful trophectoderm. You see how, are the cells very like repetitive. But for example, this is not so great. So as you can see here, there are the grades, right? Like AA. So the first letter corresponds to the ICM. The second letter corresponds to the trophectoderm. So in this case, they are both very good. And so that's why they are AA. In this case, we have a very nice ICM. The trophectoderm is good, but not as beautiful as this one. That's why it's B. But in this case, we have both really bad. That's why it's a CC. So basically, it's not actually, it's pretty straightforward how we grade the embryos. And also we look at not only, as I said, at the ICM or the outside of the trophectoderm, but we look also at the expansion of the cavity, okay? So if it's very little expand, it means the embryo is not really developed yet. So we give a degree of expansion also, like it depends. Some labs start from 1 when the cavity is so small, or some other labs start with number 2. But in general, they are like 2, 3, 4, 5. So as we go up, the cavity is bigger. And actually, 6 means that the blastocyst is completely hatched out. Okay, so now this is roughly, a brief explanation how we actually grade blastocyst. But, morphology definitely is important in embryo, but morphology is not everything. Otherwise, PGD and other stuff wouldn't be so important. So I want to say that morphology is a great tool, but does not necessarily reflect chromosomal status. So basically, we can have a beautiful embryo that is aneuploid, and we can have like a morphology, like average embryo that maybe is chromosomically normal. Okay, I mentioned before that usually the blastocysts form on day 5 and day 6, but also on day 7. Actually, is not ideal, day 7, but is still considered viable. even if implantation rate are much lower than day 5 or day 6 blastocyst. Okay, now this is we call the embryology paradox. So that is actually very fascinating because it shows that morphology provides probabilities, but is not providing any certainty. So it means that, as I said, a beautiful embryo might, implant, but might also not implant because it's not maybe chromosomically normal. And so this is really a paradox. I mean, give you the probability, yes, probably more likely this embryo, would, have a success. But it doesn't mean that for sure, because it's beautiful, will implant and will give you a healthy pregnancy. Okay, now in our field, they are coming out new technologies, like, for example, embryoscope. Embryoscope is a special type of incubator. I would say that until a few years ago, embryologists were putting the embryos in their petri dish and they were putting inside the incubator. They were living there, and then the day after, we're taking out the dish and we're looking at the microscope how many cells, etc. Now with embryoscope, this is something that it can be avoided. So basically, the embryoscope is an incubator where there is constantly a camera on the top of each embryo, and the camera record everything that, the whole development. So in the embryoscope, first of all, you don't need to take out the dish from the incubator. So it's, it can have a benefit to always leave the dish in culture without touching. But also you can see much more because you can see the real time of cleavage, how eventually, if you had like a multinucleated blastocyst that maybe later disappear, the extra nucleus, but with the embryoscope, you can see everything. And this is, I think, is very, can be very, very a good advantage for the development, understand really how is that embryo. And also when you have several beautiful embryo and you don't know which one you should choose, for example, for transfer or whatever, for freeze, etc. If you go back and look at the record of, of the whole development, you can choose, you have a better tool, something more that can help you to choose probably the one that might give to a successful pregnancy. Okay, so, and also now there are also now some new research, for example, on mitochondria. So I would say that recently are emerging in IVF field a lot of new technologies. Okay, so I believe that in the future, embryo evaluation will likely combine multiple layers of information, and like morphology, morphokinetics, genetics, metabolic signals may all contribute together to, provide an accurate embryo selection. Okay, so what the takeaway today? Well, the most important, message that I want to give everyone, that the egg quality is important. The egg quality drives early embryo development. The morphology provides us useful information, but actually cannot tell us, how complex can be the biology of that embryo. So, the embryology is, the embryology science is, growing, is a field that continuously is growing, growing, and growing. And research at the same time on embryo is, I would say that compared when I start, now it looks like impossible to me if I go back, think about what we can do now. But, embryology sits at the intersection of cell biology, reproductive medicine, and probability. So is a very complete, but at the same time, complex science. And I would say that after many years of research in IVF, embryos continue to surprise everyone. So we will still learn more and more and more. I would say that a lot of surprise are waiting for us, because we know, yeah, I would say good amount of, process, but I think there is a lot more to learn and to understand. So thank you, everyone. And these are my reference about, what I mentioned. Thank you.
Excellent, excellent presentation with the visuals were just incredible. How do you think AI is going to change embryology? A little off topic, but I'm curious what you think.
No. I think that it's gonna be great, because obviously I don't think that the AI will ever replace embryology. The embryologist will always be there, or just to drive the AI. So I guess that it's gonna be great, because it will be a combination of the human being that evaluate, for example, the embryo, but at the same time the AI can give us like information that we are not able to to see, and probably even to understand. So I think that honestly, I'm excited about.
Yeah, very exciting. I mean, all of medicine.
Yeah.
I think AI and endometriosis is going to be incredible. What like are there, I don't want to say dysfunctions, but are there things that you see specifically when you were talking about eggs and you look at them and you go, "Oh, this person must have endometriosis"?
Well, not really. And I want to be honest about this, because well, this is just, let's make it like a short story. But when I started working as an embryologist, I still remember that at the beginning, my lab director was always say, "Oh, you see these eggs? They are dark because she must have endometriosis."
Wait, we're losing the connection. Sorry.
Do you see? You are like stuck. I don't see.
No, we're starting to lose the connection for some reason.
Okay. So
it could be here. We don't know.
Can you hear me?
I can hear you, yes.
Good. So I was saying that my lab director, at the beginning was telling me, you see, these eggs are dark, there is this, there is that. So she must have endometriosis. But honestly, I didn't, in my experience, see so much difference between an egg from a person with endometriosis and a person that, because there are so many other factors that can really, affect the quality or the morphology of an egg. That I would say the most, important definitely is the age, right? So if in a let's say 40 years old, usually the eggs are not so beautiful as a 20 years old. That I can see, definitely I can tell. But endometriosis, to be honest, not really. And let me tell you, regarding this, because actually Dr. Vidali already asked me this question, and I did a little bit of research in the literature, and there are no study. Actually, apparently, there are no studies that really say that the egg morphology has some characteristic in endometriosis women.
Very interesting.
Yeah.
I think egg quantity degrades much faster in the person with
Yeah.
endometriosis, though quality and quantity aren't the same thing.
Yeah, no, definitely they're not, and also the, as I said, maybe, for example, I'm pretty sure, and actually I found some research that yes, the embryo quality might be affected by people with endometriosis. So the morphology that I can see of the embryo, yes, but the egg, no. For me, no, and even from apparently from the literature also.
Very, very interesting. I think we all well, we have two questions. Let's ask the Q&A question we actually
Yeah.
discussed last week, but when does someone do IVF and they have endometriosis, and when does someone do surgery instead?
Well, so basically, okay, so the problem is not doing IVF. The problem is doing transfer. So obviously, if you freeze your embryos before the surgery, it's actually is the perfect pathway, because you should freeze the embryos, then you should have your surgery, and then just after the surgery you can have your transfer, because the surgery is gonna clean, it's gonna remove part of the inflammation, so you cannot have a transfer.
The literature, which was discussed at length last week, and you
Yeah.
can see that video on our YouTube, is very clear. In higher stage endometriosis, stage 3, stage 4, deeply infiltrative endometriosis, that surgery prior to IVF is far superior. The
Yes.
literature is very clear that way. There's even a discussion on that video from last week why we would choose surgery over IVF for stage 1 and 2, which is just what Emma said, the business with the inflammation. Now, how does well, there's a question about adenomyosis, and how much does early stage or a low stage adenomyosis affect the chances of conceiving naturally versus embryo transfer? And for adenomyosis, the recommendation usually is frozen embryos.
Yeah, but and also I would say this, that's actually something very important, that adenomyosis, well, same as an endometriosis, is a huge inflammation, okay? But endometriosis, it's, let's say, easier to, operate. But I would say that adenomyosis, like endometriosis, both of them, especially adenomyosis, is very, I would say, risky for pregnancy loss. So if you did IVF or you got pregnant naturally, it's not really that the problem. The problem is keeping the baby, because adenomyosis, I just read an article that showed that adenomyosis is especially they saw a connection between adenomyosis and pregnancy loss on the second trimester. So I would say that you can get pregnant. You can get pregnant with endometriosis, with adenomyosis. It's not that you cannot. You can. But then you have to overcome another step, holding the pregnancy. Because both condition, they don't actually help, for a successful, pregnancy. So the early stage, I would say that is not really the implantation only the problem, so as an early stage, but is definitely also the pregnancy. I mean, holding and.
Do you have any, also with your experience in reproductive immunology, on like, are there any protocols that help hold the pregnancy better?
Well, yes, there are. As you know, every obviously steroids or intralipids. There are actually a lot of things that you can do at the same time. You can have a treatment, but especially in this case, with as you know better than anybody, endometriosis. If it's really like stage 4, you have to have a surgery. And later, after the surgery, when you do your transfer, and for if you get pregnant as well, and to continue your pregnancy, you have to definitely have an immune treatment that can be with steroids or IVIG, or there are many. It depends what kind of antibodies you have. So there are several.
Very interesting. So, can you tell us more about high-level mosaic embryos and success rate for implantation and common challenges?
Okay,
I
so
cannot. Perhaps Emma can.
so
I couldn't
basically,
answer that.
high mosaic embryo. Well, as you know, well, this is actually, we should do another webinar.
We may be back next week
Yes,
because
it's possible. So
yeah.
I might focus in on that. And so when I explained to you before about the blastocyst, I said that the blastocyst is made by two different mass. Okay, the inner cell mass that is gonna do the baby, and the trophectoderm. So obviously, when we do the PGD, so when we do the biopsy, the inner cell mass, we cannot touch it because it's the baby, but we can touch the placenta. So the trophectoderm, that is going to be the placenta. But all the cells that are, first of all, when we go there and we do the biopsy, we pick, but we don't know if that cell is really the one that represents the embryo. So when we do the PGT, when they analyze and they see the DNA, it's very possible that that cell is not the real, embryo cells, but is a mosaic. So, it's like you can have like more of those cells, or you can have just very few. So you can have a high mosaic or no, or low mosaic. But the thing is that it depends on which, aneuploidy that came out from the mosaic. If you have a good, there is a good chance of implantation or not. We cannot say that every mosaic is the same. Even not, I'm saying not like high or low, but is most importantly, what kind of an aneuploidy, for that mosaic. For example, there are some monosomy that came out to be perfectly normal babies. As we know, Dr. Vidali with Dr. Gleicher many years ago, and I was the embryologist at that time, tried with this study, they transfer embryos from mosaic that were monosomy. And the baby, when they were born, they did the karyotype, and the karyotype was completely fine. So we have to look, first of all, it's hard to tell now like this. We have to have in front of us a report of the PGD and see what kind of mosaic and everything.
here for education. I do want to mention that Emma meets with patients, people who want them to go over their fertility file to talk
Exactly.
about what the next steps could be. It's a unique experience for those with fertility and endometriosis related issues because it's not a surgical consult and it's
No,
not an IVF consult. And it's sort of got a lot of immunology based. And I do mention that she does that because, like, just like, so I'm probably better than an endometriosis surgeon in a lot of ways. Some of what she's speaking is a whole new language to me. So if you're in that situation where you're at a surgeon's office and they don't get all of this that much, that Emma can be a valuable resource for that.
exactly.
Just
And I
mention
want
that.
to,
I don't think a lot
yeah,
of people know you do that.
and I thank you for mentioning because I want to emphasize that, you know, well, also I want to say that I've been a patient. As
Yeah.
Sally knows, I've been an IVF patient and I've been an endometriosis patient as well. And well, I was a scientist, so for me it was a little bit easier and even worse for other reasons because I knew too much, and so I was very scared about any possible scenarios. But I was thinking when I was a patient, well, for me, this is, I can understand this report, okay, from embryology report or PGD report. But what about, people that are not scientists or they are not in the medical field? So how do they, yes, you go to your appointment with your, reproductive endocrinologist, you tell you, okay, you have this, that, this, but really, how much the patient understand, you know, out of these reports? So my job in this moment is really this, educate, try to let people understand the science, of embryology, and everything regarding not only IVF, as you said, immunology and fertility in general. And so this is something that, and thank you for mentioning that I want to emphasize because I think I mean, if I would be a patient, I would love to have somebody who can explain to me, things, but not like, your reproductive,
Right.
doctor.
But also independent of it's
Yes,
independent of an outcome. So like I feel like when I would go to my fertility treatments were terrible, but
yes, I
obviously I have no
know.
child. So, but when you would go there, like their goal was always baby, really they had no caring about your health. Then you would go to the endometriosis surgeon and they only cared about the endometrial and there was no like conduit
Yes,
that brought everything together that didn't have skin in the game. I think that's the
exactly,
advantage of what you
exactly.
do.
That's totally true. I mean, first of all, you know, if you want to, let's say that you are not sure if you want to do another IVF cycle because you failed the previous one. If
I
you
hate the
talk to
word
me,
failed, but it's true. Yeah.
I know, but if you talk to me, I have no, benefit if you do or not to do, So I can tell you really honestly what I think as an embryologist. As I said, for me, it doesn't matter if you do another one, I don't get anything. So there is no interest. So I'm happy to help educate a person in a way that can make, you know, the best choice in that moment. That's it.
Yes, excellent. Okay, we are rounding out tonight's fertility webinar. We end every webinar with the same question. What are you looking forward to the most about the Endometriosis Summit?
Okay, so and because you already asked me, I'm gonna repeat because I'm obsessed with that. So I really want to spread the idea that endometriosis really, really, and adenomyosis as well affect fertility. And you cannot keep doing cycle and cycle over and over again, but you have to be, I'm saying, for example, as a doctor, aware about endometriosis disease and adenomyosis. So, in my opinion, there is not yet enough awareness, but not, I'm talking about, people in general. I'm talking about doctors like OBGYN that, they say, oh, no, you don't have anything. Everything is fine. Keep doing your cycle, do another IVF. No.
I, I went to the regular OBGYN, not the excision surgeon, after my first surgery, which was 6 hours long, and I had a bowel resection. And
Wow.
I kind of was there to show her, like, look at everything you missed. And this is what she said to me. She said, you'll get pregnant, no problem with IVF. Like, it was just like people don't get the nuances that there are. So as somebody is asking for your contact information, what is the best way to contact you, Emma?
Well, they can go on Instagram at SC Fertility and Immunology, and you follow my page, and then you can DM me.
Excellent, excellent. And we'll be back next week with
Next week,
another
let's
fertility
see.
block.
It's gonna be a surprise, the topic, right?
Surprise, surprise to us
Surprise.
all. And I will see you then. For those of you that are on the link will stay open, and we will be hosting Jessica Drummond, and it should be amazing. And I thought, while we're talking about what are we looking forward to the most, I spoke with Dr. Pareto today. She's going to do our autonomic lab. She said, stop
Hmm.
calling it the POTS lab and start calling it the autonomic lab. And I think what I am looking forward to the most is understanding the neuroimmune system under attack. And so, like, are we beginning to look at endometriosis as a neuroimmune condition, and how it interconnects with HEDS and perhaps mast cell and POTS? That's what I spoke to her for like 20 minutes today. I'm really looking forward to that. So,
Actually, super interesting. I mean,
yeah.
it's something very new and, new
And I
and
think,
not new, but
right, I think
yeah,
those who spent time with patients doing IVIG and why they've made certain mediator decisions for fertility, like, I think now we're going to see some of the reasons why unfold in
yeah,
terms of the whole disease. Yeah.
yeah, exactly. So it's gonna be great.
Yes. All right. If you're looking to register for the Endometriosis Summit, www.theendometriosis summit. Look, heads up, people, it's going to close in person probably next Tuesday morning. We'll keep virtual open till Friday, but then you're out of luck because then you're going to miss it all. So we will see you.
And
Emma
don't miss it. Don't
is
miss
gonna,
it.
yeah, don't miss it. Emma's
Don't
gonna
miss.
log off, and
Yes. Bye,
Jessica will
everybody.
be here
Thank you.
soon.
Bye bye.
Bye.
Thank you.
Mwah,
Thank you.
mwah.
Bye.
All right. All right. So Jessica Drummond will be here soon, and I'm gonna take a little break for an antacid, by the way. We have to do it this way. Okay. Stop recording.